Fibromyalgia, often abbreviated as FM, is a chronic pain condition that affects between 2% and 6% of adults in the United States. Beyond the persistent pain, FM brings significant challenges to quality of life and imposes a heavy economic burden. Patients with FM typically face healthcare costs nearly 3 times higher than those without the condition, and they visit doctors and emergency departments much more frequently. Impact extends beyond direct medical expenses, as productivity losses and caregiver needs also weigh heavily on society. With only 3 FDA-approved medications, pregabalin, duloxetine, and milnacipran, plus the off-label use of amitriptyline, choosing the most cost-effective treatment is crucial for both patients and the healthcare system. This video explores which medications deliver the best value for adults with moderate to severe FM, considering both health outcomes and economic impact. Determine the best value among FM medications. Researchers used a Markov model to simulate the lifetime costs and health outcomes, measured as quality-adjusted life years or QALYs for each treatment. The analysis included adults with moderate to severe FM, reflecting real-world demographics where most patients are women around age 48. Medications compared were amitriptyline, pregabalin at several doses, duloxetine 60 and 120 mg, and milnacipran. The study evaluated both direct medical costs and broader societal costs, such as lost productivity. Results showed that duloxetine 120 mg consistently provided greater health benefits, and when societal costs were included, even saved money compared to amitriptyline. Pregabalin 450 mg also offered better value than amitriptyline from a societal perspective, but duloxetine 120 mg remained the top performer. Study found that the cost-effectiveness of FM treatments depends on both the health improvements they provide and the broader economic impact. Duloxetine 120 mg not only improved quality of life more than amitriptyline, but also reduced overall costs when indirect factors like work productivity were considered. Pregabalin 450 mg was also cost-saving compared to amitriptyline from a societal perspective, though duloxetine 120 mg still offered the greatest net benefit. Lower doses of pregabalin and duloxetine, as well as both milnacipran regimens, were less effective and more expensive than amitriptyline. These findings highlight the importance of considering both direct and indirect costs in treatment decisions, and suggest that optimizing medication dose can significantly improve value for patients and the healthcare system. These results have important implications for both clinical practice and health policy. For patients with moderate to severe FM, duloxetine 120 mg stands out as the most cost-effective option, especially when considering the full societal impact. Pregabalin 450 mg is also a strong alternative, particularly for those who may not tolerate duloxetine. Findings suggest that healthcare payers and policymakers should prioritize access to these high-value treatments and consider the broader economic benefits of effective FM management. However, individual treatment decisions should also account for patient-specific factors, such as side effect profiles and comorbidities. Ultimately, value-based care in FM means not just controlling symptoms, but also maximizing quality of life and minimizing the total burden on patients and society.